It's been a fascinating day till now. My name is Lien de Proost. I am from Belgium and I'm working in the Netherlands for about 5 years now. And I have one disclaimer: I'm a philosopher. Yeah, so yeah, you should remember when you ask questions that I'm a philosopher. But I'm going to talk about the perspectives of adults born preterm, because the questions that came up in the previous presentations, questions like, yeah, should we do everything we can? Well, as an ethicist, I can say no, and also the participants of our study would say no. And I'm going to explain a little bit more about that. I'm affiliated as a postdoctoral researcher with the Leiden University Medical Center in Leiden and the Erasmus Medical Center in Rotterdam. So what we have done in the past year is actually named the TINY study, towards individualized care for the youngest. And the TINY study consisted of multiple studies, actually. We started, of course, with the literature because we wanted to know how people were reflecting already on personalized care or individualized care or care in general at the limits of viability. And then mainly guidelines, lower treatment limits, and how we should provide care to actually our tiniest babies. Then we did a survey study on this topic with healthcare professionals in the Netherlands. We did a focus group study with adults born preterm. We did individual interviews with experienced parents. And what we're doing now is, the topic came up already, is also doing mixed focus group studies with adults born preterm, but also parents and healthcare professionals on the new technology of the artificial placenta. But today I will speak mainly about the TINY-1 study, which is our empirical research with adults born preterm. But first, I will give you some background on the Dutch context, because it might be important to really understand the results that we came to. So actually, in the Netherlands, we have a guideline dating back to 2010, and this guideline has a lower treatment limit of 24-week gestational age. So if an infant is born lower than 24 weeks gestational age, we provide palliative care. Then between 24 and 26-week gestational age, we have a gray zone of parental discretion, actually. So we just really want to share the decision with parents. If an infant then is born later than 26-week gestational age, we provide intensive care. This guideline dates back to 2010, but 2 weeks ago, actually, because I have to say it because there are many people from the Netherlands in the room, 2 weeks ago, the new Dutch guideline became public, so I will say something about that shortly. But I can say now already that the lower treatment limit is still 24 weeks gestational age. I'm not going to go into the outcomes or the numbers because I'm a philosopher, but still, I just want to mention shortly that in general, around 50% of the infants born at 24-week gestational age survive in the Netherlands. From this 50%, 1/3 has severe complications, 1/3 has mild complications, 1/3 has no complications. These are the numbers in general. And this lower treatment limit of 24 weeks, it wasn't always the same. If we look throughout the years or through the history of the Dutch guidelines, we see that with every new guideline, this lower treatment limit has been changed with 1 week. Before 2005, we were only offering resuscitation with a zone of parental discretion and shared decision-making from 26 weeks on. Then in 2005, we got a new guideline, so the lower treatment limit became 25 weeks. And then in 2010, it became 24 weeks. In 2020, a working group was initiated for evaluating this 2010 guideline, which resulted in the new guideline of the 2024 guidelines. So they worked 4 years on this evaluation. But for now, just important to keep in mind, the lower treatment threshold is still 24 weeks. As you know, I don't have to say much about this, but there is much international heterogeneity when it comes to peri-viability guidelines. And the Netherlands is often described and that is a euphemism, often described as an outlier. Because in contrast to the Netherlands, there are many countries with a lower treatment limit, 22 weeks, 23 weeks. We heard about that in the previous presentations. But also there are countries who have a uniformly active approach. So no zone of parental discretion. Also, that is something that came up in the previous presentations. And then also, what is important to know that especially the 2010 guideline in the Netherlands is based solely on gestational age. So that means that we, in theory, only look at gestational age. So this cutoff of 24 weeks, gray zone to 26 weeks, actually, this is the only prognostic factor that, in theory, we take into account. There are, of course, guidelines internationally that take into account multiple prognostic factors, such as the UK. I'm sure you're familiar with that guideline, which takes into account gestational age, but also sex, antenatal corticosteroids, and so on. So why is that? Why do people take into account more prognostic factors? I'm sure you also know this tool. I've put in I created some random 24-weekers, not really random, but just a little bit random, just to show you how the outcomes can differ for 2 infants born at 24 weeks gestational age. And we also heard already about the Cinderella effect. There are some big disadvantages with gestational age-based guidelines, such as the one we had in the Netherlands until 2 weeks ago. This is also something that I just want to show, but it's not necessary anymore. The survival rates for people way younger than 24 weeks are actually quite good, but that's the survival rates, of course. But still, when we look at the international literature, there are some articles who are quite critical on the Dutch approach. Dr. Barrington, for example, also is quite critical of the Dutch approach, of course. But we wrote an article on this, and this article is called "The Edge of Perinatal Viability, Understanding the Dutch Position," because indeed, the Netherlands is a quite interesting context when it comes to extreme prematurity, but also other bioethical dilemmas or bioethical topics. Because when you look at the Netherlands and you look at their abortion policy, but also euthanasia policy, they can be described quite liberal. And then if you look at the extreme prematurity policy, there were people saying, well, that's not liberal at all. Why are you so conservative in this regard? But then still, we wrote an article. It's not a topic of the lecture today, so I'm not going into this. But still, it's important to see that it has to do with values. It has to do with values such as quality of life, but also individual responsibility, freedom of choice, which actually made that it doesn't come down to conservative versus liberal, but it actually comes down to safeguarding a certain standard of quality of life. Now, I already said that the Netherlands is getting much critique on their policy. Many people are writing articles on what are they doing in the Netherlands, why are they sticking to their conservative policy. But that's why I want to ask you this question first, and it will become clear why. Oh, the organization added the not sure option. I didn't. I just put yes or no, but they wanted real nuance. So no, but that's maybe too easy. But still, 29% says no, and many of you are unsure. So why do I want to ask you this? Well, very, very recently, it's a very small sample, but still, very recently in Norway, they asked 80 pediatric residents whether they would resuscitate their hypothetical extremely premature infant. It's only 14% that says yes. And in many centers in Norway, there's also no room for shared decision-making whatsoever. It's a uniformly active approach. So this is interesting. So these are things that we should take into account when writing critical articles on policies. So that was that. Well, when it comes to background. But now I just want to give you some more background on what we actually wanted to know from our participants. And actually, we looked internationally what kind of peri-viability guidelines were available. And we categorized them into 4 different groups. Of course, there are countries or parts of countries who have no guideline whatsoever. So they have a fully personalized approach. They just look at the infant. They, of course, they have this kind of, they follow some kind of informal guideline actually, but there's no official guideline, so that's an option. The second option is a gestational age-based guideline, such as we have had in the Netherlands, a strict cutoff of X weeks gestational age. A third option is a gestational age-based plus guideline. So then you really take into account gestational age, but you also take into account other prognostic factors just to fine-tune the prognosis, so to speak. So actually, you don't have a strict cutoff here. That's the third option. And the fourth option is a prognosis-based guideline. So with this type of guideline, you would say you would actually use this kind of algorithm or something like that. And you would say, well, from like 70% on, we would offer intensive care, or 60% or 80% or something like that. So these are 4 categories, 4 possibilities of guidelines. And we actually wanted to know from our participants, so adults born preterm, but also parents and healthcare professionals, what is good policy at the limit of viability? These 4 types of guidelines do have some advantages and disadvantages. And we didn't, of course, beforehand disclose these to our participants, but I do want to disclose them really shortly with you. So if you have no guideline, an advantage is, of course, you can fully adapt, you can fully personalize, but still then you have to make a decision. How do you do it if there is no guideline? So there might be a risk for arbitrariness here. The second category, gestational age-based guidelines, an advantage is that it's really clear, there's uniformity, there is just really clarity for what you have to do at this moment because the decision is quite difficult, so there's an advantage. However, the Cinderella effect is the great disadvantage of this type of guideline. The third type of guideline, gestational age-based plus guidelines, an advantage is that then you really look at what, in ethics, there is this great rule of thumb that is called you have to treat equals equally and unequals unequally. So now what does that mean? But still, it's an important rule of thumb to start thinking about questions like this. Because what makes 2 infants equal in this case? To be very short, it is not that they're both born at 24 weeks, because that's actually not really relevant. What we really want to know is how it will turn out for them. What are their outcomes? So we need to look for infants who are equal, not just because they're both born at 24 weeks gestational age, but because they're born having a good chance of a good outcome, stuff like that. So that's an advantage of a gestational age-based plus guideline. But then questions can come up like, what factors do you consider? How do you weigh these? And it may require a lot from a healthcare team. The fourth option is a prognosis-based approach. As I said, you can use an algorithm and use a cutoff of like X% chance of a good outcome. An advantage is that you personalize your assessments, but still, just as with the GE-based plus guideline, what factors do you consider? How good is good enough? I already said, you can use 70, but also 60, 80, 90. That's very difficult to decide. And also, I can speak of algorithms very easily right now, but we don't really have them. And we certainly don't have algorithms of which we now know that they are good in practice and they have really good predictive value. Also, there is in general a lack of an internationally validated prognostic model. So this was the theory. Now the interesting results come. I will first tell you who we have spoken to. So who were these adults born extremely premature in the Netherlands that we have done our focus groups with. Then I will show you the results when it comes to this main question. So we have asked them, we have these internationally, these different types of policy. What would be your preference? And then I will show you some incidental findings. Because as you know, the group of adults born extremely premature is actually not really prominent in the literature. They're actually a forgotten group, and that's a shame. And we were doing focus group with them, actually focusing on these questions, but that was clearly not enough because they had many stories for us, many messages to get out to you, actually. So that is also what I will try to do today. First, go into some results for our research question, and then discuss some incidental findings. But first, I would like to know what your preference would be. I know it's just intuition and that you don't really have time now to dive deeper into what it actually, or how the guidelines actually work, but still you do have enough information, I think, to have a first preference. Okay, that's interesting. And no one would prefer no guideline? Because that is interesting, actually, because when we started our study, there are groups who are publishing on how unethical it would be to have a guideline for extremely premature infants, because they would be like, yeah, but we don't have these kind of guidelines for other people in the intensive care unit. So why would we need this guideline for this group? So they think it's discriminatory to have a guideline. So we would expect from our participants also to be like, yeah, of course there shouldn't be a guideline. You should just look at who I am. But you don't agree. And our participants actually also don't agree. I will explain in a minute. So most of you prefer a GA-based plus guideline. Okay. Now I will share the other results. But first, our empirical research. So as I said, we have done research with parents, adults born preterm, and healthcare professionals. Today, I will mainly speak about the Tiny One study, and we have done focus groups, 4 focus groups with 23 adults born preterm. They were all born at the, well, so-called limit of viability, but they varied in age. So they also varied like in weeks gestational age. But these are the characteristics, of our study participants. Most of them were not religious. We had some twins, and most of them were female. We really tried to have a really, really diverse group. That was a challenge, and we might need to do it again with an even more diverse group, but still, we did manage to have some variety when it came to outcomes. So this is self-reported, actually. We just asked them to not to fill in a questionnaire or something, just to tell us what they were struggling with, and these are the results. Okay, so the guideline preferences. As I said, we would first expect people to be like, no, a guideline shouldn't be there. It's also not there for other groups, shouldn't be there for us. But there was actually great consensus even among, like, in every focus group, but also among focus groups, because we did one extra session with all the 23 of them, which was kind of informal, but I will mention it now. And the consensus was that no guideline is not an option. A guideline provides guidance, and also what was the main reason that they wanted a guideline is that it protects against physician bias. And we don't really know where this comes from. Does it have to do with trust? Does it have to do with how they have spoken about this with their parents? We don't really know, but they thought it was very important that a guideline protects against physician bias. On the other hand, I will mention now that we also asked the parents, would it be an option to have no guideline? And they would also use the argument from protection, but they would say, we need a guideline because a guideline can protect us not from physicians, but from ourselves. They said a guideline has a protective function against the so-called instinct of parental saving. Because if you provide the option, they will say yes. So this protection function and this protection argument when it comes to there should be a guideline came in the premature group as well as in the parent group. And I also brought a quote: even if there's no guideline, you still have to base your decision on something. Or will doctors then just don't give any advice? Will it be up to the parents? Will it differ per doctor? Who has the final say? So this arbitrariness is a worry when there is no perinatal guideline. The second option then, the gestational age age-based plus, the gestational age-based guideline, sorry, so the guideline that was at the time the Dutch type of guideline. Everyone was actually very, very, very critical of this kind of guideline. And that came down to mostly the statement that we are more than just this number. They thought it was too black and white. They thought it was too rigid. I also brought a quote here. Of course, it matters how much I weigh when I'm born, but that's not who I am. Personalization means that it's more about the person than it is about the numbers and the statistics. And of course, this is a difficult statement because we do need numbers and statistics, but the incidental findings will probably say something more about how we should interpret comments like this. When it comes to the third category of guidelines, the gestational age-based plus guidelines, so you use gestational age, but also other factors to fine-tune the prognosis. This was the type of guideline that was mostly preferred by all of our participants. And I'm not discussing that study right now, but also by the parents and also by all the healthcare professionals that we interviewed. Because the main argument in favor of this type of guideline was that it is a kind of balance between standardization. On the one hand, there is this structure, this support that people value, but also on the other hand, there is room for individualization, personalization, and looking at the people or the family that is in need of care. The last type of guideline then raised much discussion because the discussion mostly centered about then what does a good outcome actually mean? Which factors do you consider? How do you weigh them? There was much discussion also from our group on factors like socioeconomic status, ethnicity, also sex. There were many quotes about how parents were told. This is then what the adults born preterm told us about their parents, but parents were told that you should be glad it's a girl because they will fight. And these comments just don't work because these comments apparently are being discussed in these families for about 30 years, and it's damaging and traumatic, apparently. Then I also brought quotes. How does it work in practice? Is it a kind of score? You can breathe on your own, +3, you can't walk, -5, that's problematic. This is how they perceive how they perceive that this works. Of course, it doesn't really work like this, but still, it's important how they perceive this. For example, being able to walk, how does that relate to your happiness, well-being? One person ends up in a wheelchair, accepts it, being super happy. Another person deals with it very differently. Also, there were many statements made about how it matters in what kind of society you value a kind of prognosis. If society doesn't care for people in wheelchairs, then this may affect how you interpret these prognoses, and that might in turn be problematic, according to our participants. So prognosis-based guidelines weren't really in favor of our adults born preterm. As I said, there was much discussion on including prognostic factors because we all have this kind of list based on the literature, based on existing guidelines, based on evidence-based medicine. We know gestational age matters, sex matters, corticosteroids matters, but we actually also do know that socioeconomic status matters, housing conditions, maternal BMI, all those things. Should we take them into account? This is really interesting. I would love to hear some ideas, actually. So it's kind of 50-50. Also here, I didn't add the unsure. You shouldn't be unsure in this presentation. So the majority would say yes. So that's actually very interesting. Maybe we can focus on that a little bit in the discussion. Okay, so now I have brought 3 actually main incidental findings from our qualitative research with adults born preterm. And the first one is aftercare is highly important for infants as well as for parents, because we heard a lot of stories about how the pain that the parents experience is actually brought on to the infants, and that might be problematic. And also aftercare is a topic that was very, very present in all focus groups. The quote says, we've always had to search for answers. I only got an answer 3 years ago. That cannot be in this day and age. If there are complaints, someone should be followed up. And it goes on. We also heard much stories of diagnoses that were gotten way too late. People who thought they had asthma for 30 years and then it appears to be BPD after all. Stories like that. So aftercare is very, very, very important. The second incidental finding is communication is key. And actually that is important when it comes to the quotes that we earlier saw on you can't walk, -5, you can't breathe, -3. It really, really matters not just what you say, but also how you say it as a healthcare team. And this is actually a quote that illustrates what I mentioned earlier. I know from my parents that they were told to be glad it's a girl, she will fight. Her parents find that quite difficult. And we heard similar stories from adults born preterm, but we also heard quotes like this in our study with parents. So that's actually a very important topic to discuss further. So maybe it might not be that like we really shouldn't take into account socioeconomic or social factors, but still we really need to start a discussion on how to discuss them, these socioeconomic or non-medical, because it's an artificial line, but still non-medical factors, because these things haunt people apparently for a very long time. And then a third incidental finding has to do mainly with how the adults born preterm talked about personalizing care, individualizing care, and having the feeling that they really matter and not just their numbers. Small things can really make a difference. They don't have to take much time. They just take some time, some empathy and some really notice the small things. So this quote says, I couldn't breathe independently, but at some point when I was off the ventilator, I apparently made a loud sound. And the nurse wrote in my diary, you're making nice sounds. Maybe you have a beautiful voice. Maybe you are musical. And she got into music. She has this diary where she reads the stories back from the time in the NICU when she has a hard time. And this really helps that she was seen. Because if you ask these adults born preterm what does it actually mean to receive personalized or individualized care, they mainly summarize it as being more than just a number, feeling seen, feeling heard, and it might be really abstract, but it just has to do with really, really small things that don't actually take much time, but they do take, and actually not really that of an effort either, but still you have to really notice them. So the conclusions for now are that a peri-viability guideline based upon our empirical qualitative research should not rely solely on gestational age as a determining factor, because they are more than just this number. We have to treat equals equally, but equal doesn't mean in this case, think of the Cinderella effect, it doesn't mean just both being born at 24 weeks, there's more than this. Second of all, peri-viability guidelines should encompass an element of discretion and avoid rigid cutoff points for treatment. It really matters what parents have to say and what their values are when it comes to peri-viability decision-making. And third of all, establishing a lower treatment limit for extreme prematurity can only be deemed ethically responsible if it is coupled with adequate attention to long-term follow-up care for both infants and parents. And that I hope that is actually my main message for today, and that you take that with you. We can think of guidelines as much as we want, but it's about the long term. It really is. Thank you so much. I have one extra quote, by the way. This is a quote from one of our participants who was describing what a perfect guideline, according to her, is. And this is the quote: a guideline lays a general foundation, and then you can individually build the house. How you're going to build it, you decide and do together. So that's actually a very good summary, I think, of what a good guideline is. Sorry, I forgot that I had the good quote. Come on.